esteemed CAG Sri Sanjay Murthy ji, other distinguished members of the CAG establishment, and all the others who are gracing this particular morning's event as a part of the overall deliberations of the Accountant Generals of India's conclave. It's indeed a privilege to be here talking to people who make the most important decisions about how money should be handled when we in the health sector keep aspiring for more and more money and hoping, like Oliver Twist, that our prayers will be answered with greater allocations. But of course, we also realize that we not only need more money for health, but we also need more health for the money, which means that there has to be efficient utilization of resources, and that's where your astute analysis of how the money is being expended and whether it could be better spent to achieve more impactful results becomes very important. I must start with a little anticipatory bail application. I was told initially that I have to speak on public health, which is a vast ocean. So I did choose a topic which is part of that, which is on universal health coverage. I'll try and cover a bit of that. I had no intention of pulverizing you in the morning with a PowerPoint presentation, but I thought in order to yield some structure to the presentation, I shall use some slides. There are far too many. I'll skip some of them, but the presentation will be available to you in case you would like to refer to that later on. But it was heartening to hear in the morning that one of the chief themes is a continuing conversation on how to proceed from silos to greater synergy across sectors and across your own work. In fact, silos to synergies could be the theme of public health, because public health is indeed the most multisectoral of all disciplines. Whether you're talking about water and sanitation, which is where public health started from, or whether you're talking today about environmental pollution, of which we are all suffering here today in Delhi, or whether you're talking about urban transport and urban design, whether you're talking about food and agriculture systems which have to provide appropriate nutrition at affordable prices to everybody, because nutrition and health, again, are inseparable. Or even the changes related to climate change, obviously, all of these matter to public health. And having transitioned from a career in clinical medicine and cardiology at the Indian Institute of Medical Sciences to public health, I've frequently been challenged as to what's the distinction between clinical medicine and public health. My response is that clinical medicine delivers health in retail, whereas public health delivers health in wholesale. Because public health actually deals with the varied and multiple determinants of health across multiple sectors, to identify and influence them through policies which have a population-wide impact, through systems which help to deliver services, programs which configure and direct those services to specific areas of action, and with strong community engagement as well. All of that comes within the ambit of public health. So I, therefore, will apologize to you that I will not be able to cover that whole ambit, but I will focus on universal health coverage, which is one of the key elements of providing those services with appropriate quality and equity. So let me start off with where we draw inspiration from, which is India's National Health Policy of 2017. The preamble clearly states as its vision that we have to achieve the highest possible health and well-being for all, focusing on a preventive and promotive healthcare approach across all developmental policies. I emphasize all developmental policies. It seeks to provide universal access to quality healthcare services, ensuring no one faces financial hardship as a consequence, and emphasizes strengthening the government's role in all dimensions of health systems. So if we really take that as the vision, then public health has to serve that vision in every manner possible. Now, we do place a great value on health, quite often on individual health. And certainly, it has both an intrinsic value and an instrumental value. It provides, at the intrinsic level, well-being, self-care, functionality, cognition, sex and reproductive functions, leisure time activity, enjoyment of culture, and social interactions with family and friends. All this would not be possible if somebody were unwell. But it also has an instrumental value in providing access to and utilization of education, employment, income generation, uptake of new skills, travel, participation in competitive sports or performing arts, and social interaction through wider networks, through extended groups. So if we do attach so much of value to health and recognize that health is also a very important input for national development in terms of a productive population, of reducing healthcare costs, and in multiple ways is an important pivot for economic development, then the question comes in, how healthy is India today? India did gain a lot of health after independence. Life expectancy at birth has risen from 32 years in 1947 to 70.6 years in 2024. Maternal mortality ratio has fallen from 97 from 2000 to 100, from a value of 2,000 per 100,000 live births in 1947. It's fallen down to 97. Infant mortality rate has fallen to 28 from 145, and total fertility rate has fallen to 2, though some states are still above 2 and need to catch up. Life expectancy birth has certainly increased in India from 1800 to 2020, and you can see this takes off from around 1920, when a lot more of self-governance was reflected even in the pre-independent India and across the various states. And after independence, of course, there's been a great surge in our life expectancy. However, the question that needs to be asked is it just life expectancy or healthy life expectancy? When we define healthy life expectancy as the number of life years lived without undue disability or the burdens imposed by severely limiting disease, then it is the healthy life expectancy that matters, not just life expectancy. So if you really look at where we are in terms of healthy life expectancy, India has had at least a decade of shortage in healthy life expectancy as compared to the total life expectancy. And India at 60 years is falling short of Bangladesh at 64, Sri Lanka at 67, Thailand at 68, and China at 69. So there is a lot that we need to aspire to in terms of catching up. And our goals, of course, are also very important. That for 2047 in Viksit Bharat, we have set as a goal a life expectancy of at least 85 years and a healthy life expectancy of at least 75 years. Hopefully, the gap of 10 years will shorten by that time. But it also needs to be reminded that the gap between healthy life expectancy and life expectancy, or between life expectancy and healthy life expectancy, is more in women than in men. So there is a considerable amount of issue in terms of gender equity that needs to be addressed. While women do live longer, even in India, than men, because of a biological advantage, the number of years lived with health are not that many because of a variety of reasons where there is a confluence of multiple disadvantages of their life course, which influence their health as well as access to health services. Now, India lags behind developing economies on critical markers of health such as infant mortality and life expectancy at birth. I'm not going to go through all of them. I'm certainly not going to compare with the US, European Union, or Russia, or Japan. But when you look at Brazil, Sri Lanka, Bangladesh, Vietnam, we are still falling short in terms of infant mortality as well as total life expectancy compared to these countries. And while India has several success stories, what we now need to do is to really look at how best we can make up our ground by comparing with other countries in South Asia and Southeast Asia, whether in maternal mortality ratio, or whether in vector-borne diseases, or whether in immunization outcomes. We need to really look at what we need to do in terms of our own shortfalls. For example, India has achieved a large drop in vector-borne diseases with a drop of 71.8% in malaria cases and 73.9% in malaria deaths, but still needs to achieve elimination of malaria, which is a target of our Sustainable Development Goals for 2030. Similarly, universal immunization program has certainly increased the amount of immunization coverage, but we are still way short. We have increased from 61% to 91% in 2019. But most of the Southeast Asian countries have achieved higher coverage rates and better immunization outcomes. Even during the period of its civil conflict, Sri Lanka had higher immunization rates than we've had. When we look at infant mortality rate, for example, there are so many differences between the states. There's no point only in talking about national aggregate values, because we definitely will have to look at state level values, and we can see that while Kerala is in fact at the moment ahead of even the United States in terms of infant mortality rate, certainly comparable with the best in the world, but we know that at the other end we have Madhya Pradesh with 46, almost an 8-fold difference here. So there's a tremendous amount of difference that we need to bridge between the various states of India. 8 EAG states plus Assam contribute to 50% of India's population. They contribute to 59% of childbirths, but they contribute to more than 70% of infant and under 5 deaths, and 92% of maternal deaths. And therefore, when we look at the other areas too, like infectious diseases, TB, malaria, and other vector-borne diseases, HIV/AIDS, non-COVID zoonotic infections, bacterial infections, especially at extremes of age, infants and the elderly, influenza, these continue to be challenges of the health system. But at the same time, a very major challenge is emerging in terms of antimicrobial resistance. We are going to be seeing a very large number of people afflicted by infections, including tuberculosis, but also other bacterial infections, where the antibiotics will not be effective in the next 20, 30 years. And there are very few new antibiotics on the pipeline. So this is going to be another major challenge that the doctors and health systems of the future will have to contend with. And when we talk of vector-borne diseases, these are going to rise with climate change. And with global warming, we are going to see the mosquito-borne diseases rising to higher altitudes and spreading out in greater geographies, geographical width. At the same time, we have some challenges related to nutrition. If you look at our rates of childhood stunting, wasting, and underweight, stunting being low height for age, underweight being low weight for age, and wasting being low weight for height. Then in all three areas we have had serious problems, and stunting remains a major challenge for us because it is not only a matter of making the child more susceptible to infections now, but there is a likelihood with nutrition being replenished, the child may actually grow stunted and obese and is likely to have early onset of cardiovascular disease and diabetes in later life. So there are serious developmental challenges. There is also a serious loss of cognitive power, of brain power for the Indian population if we don't address our nutritional challenges. So this is going to be one of the critical areas for intervention. But at the same time, we are seeing that from infectious diseases, maternal and child health perils, and nutritional disorders, the pendulum is swinging towards a greater burden of non-communicable diseases like cardiovascular diseases, diabetes, chronic respiratory diseases, and cancers. Indeed, NCD deaths in 1990 contributed about 35.8% of the deaths. By 2019, we started seeing them going up to almost 65% of all deaths. Other emerging health issues also will need, as I said, a great deal of attention. Diabetes, we have seen, according to the latest study from the ICMR, the in-diabetes study, that 136 million persons having pre-diabetes and total around 315 million of our population are estimated to have high blood pressure. So 101 million cases of diabetes, 136 million with pre-diabetes, and 315 million with high blood pressure. Mental health, nearly 15% of our Indian population is affected by mental health disorders. And depression, which is the most common mental health disorder, affects nearly 5% of the population. Air pollution is estimated to contribute to about 1.6 million early deaths in India annually. And climate change is now bringing forth a huge host of disorders, waterborne diseases, vector-borne diseases, impact on food and agriculture systems, nutrition, as well as non-communicable diseases. And we are seeing all of that now compounding our public health challenges. Now, health systems matter. 1 in 4 adults in India has hypertension, according to the ICMR survey, national survey. But only 10% of them have their blood pressure under control. So those with inadequate detection or those with inadequate control are more likely to be susceptible to heart attacks and strokes and kidney failure, and they are going to be really inflicting a great deal of demand on our health system resources. Now, there are lessons that we need to draw from COVID-19. What we need is an efficient, equitable, and empathetic health system in the steady state, to be functioning in the steady state, to ensure a swift, strong, and sustained response in a public health emergency. We cannot scramble when a public health emergency hits us unless we have a very functioning and dependable health system even in the steady state. And primary care is pivotal to a well-functioning health system. This is very clear even during COVID. It was in primary care that we had to deal with most of the initial diagnosis. We had to do with the contact tracing. We had to deal with isolation. We had to deal with vaccination. All of these are essentially primary care functions. And failure of urban primary health care in India allowed the virus to enter from airports, spread around the cities, go to the neighboring districts. If we had a very sound urban primary healthcare system, it could have been contained much earlier. NCDs contribute to infectious disease, morbidity, and mortality. And another thing, while we do talk about infectious diseases as being very important, we must remember that majority of the deaths that took place, majority of the critical care requirements in COVID-19 were because of comorbidities which are non-communicable diseases: diabetes, hypertension, obesity, and pre-existing cardiovascular and respiratory disease. So this kind of silos that we have some communicable diseases, some non-communicable diseases, that is detrimental to a well-functioning health system. So other lessons from COVID-19 are that we need a large, multi-layered, multi-skilled health workforce, even in the era of digital health. Universal health coverage is needed for appropriate and affordable health care to all. A strong public sector capacity is needed even when private sector is available. Higher levels of public financing are needed for health from the center. That's more money for health, and public health expertise will improve health gains from the investment that we make. That's more health for the money. India's health system has suffered from low public financing for health for decades because health has not been seen as an investment for economic growth. A gentleman called William Baumol, an economist who was very influential in the United States in the latter half of the last century and in the early part of this century, said, healthcare is a cost disease. Unlike investments in agriculture and industry, it does not yield commensurate returns, economic returns. On the other hand, it drains away a fair amount of money. It is that cynical viewpoint which influenced some of our policymakers as well in this country, and therefore health initially was not seen as a worthwhile investment. It was seen as a part moral obligation, but not as an economic investment. But that idea has been disabused by several commissions on investing in health, led by Jeffrey Sachs for the World Health Organization, Larry Summers, and Dean Jamieson and others for the Lancet Commission, and so on. So now we know, everybody recognizes that health is vital even for economic development. So when we look at where we fell short, if you look at health financing in 2017 and 18, if you look at government health expenditure as a fraction of total health expenditure, India is 30%. And as a result, out-of-pocket expenditure at that time was 62%. Sri Lanka spent 56% as part of the government health expenditure, that was of the total health expenditure. Brazil, 46%. Leave aside Japan, 84%, or UK with NHS, 83%. Even the United States, the poster child of privatized care, spent 48% of its total health expenditure from government health expenditure on the Veterans Administration system, Blue Cross, Blue Shield, etc. So you cannot achieve universal health coverage without adequate government and public financing. If you look at the national health accounts of 2017 and 18, again, we find that government health expenditure was only 1.35%. It was 1.15% in 2013 to 14. We have been mostly stuck around that figure of 1.4%. And we now see that it was slightly higher in 2019 and 2023. But still, out-of-pocket expenditure was about 47%. And the WHO and the World Bank say that unless you actually limit your out-of-pocket expenditure to less than 20%, you would not have achieved universal health coverage or unlikely to achieve sustainable development goals. Now, if you look at health workforce shortages, the WHO says that in order to achieve SDG and UHC goals, we need 44.5 health workers consisting of doctors, nurses, and midwives to achieve this. We have 8.3 doctors and 17.4 nurses and midwives, plus 25.7. And if you add dentists and Ayush doctors, then it's 33.7. Sounds good. However, if we take those who are actively still in service, available for serving, public or private, not dead, not retired, not flown abroad, then the numbers are lower. Then if you adjust further for qualified, because there are so many Bengali doctors who are identified in census without qualifications who call themselves doctors, then the actual figures here are, we have for 10,000, 4.8 doctors and 5.7 nurses. So we're woefully short of the required numbers in terms of our health categories. And I'm not going to go through this, but just to say, huge shortage of specialists, even in the community health center, where specialists are required. While the total number of required specialists at CHA was 21,924, only 4,405 specialists were actually available. India currently has great shortage of pediatricians, of surgeons, of physicians at the community health center, and anesthetists as well. So if you really look at the distribution, again, there's a huge skew towards urban concentration. Even Ayush doctors, who we think intuitively are more likely to be available in rural areas, they are also much more urban concentrated. May not be in the metros, but certainly in the smaller cities. So again, we are seeing a huge urban-rural disparity. So challenges to health services are how best to deliver value to patients and communities, what we need to deliver to people, whether through public health services to communities or to individual patients through actual health services in hospitals or healthcare facilities, are how do we ensure access, reduce costs, and improve quality of services. And we therefore look to universal health coverage to provide the way. The building blocks of universal health coverage are service delivery, health financing, and governance. The outputs are service access, readiness, quality, safety, financial resources, which are pooled, and crisis readiness. And in terms of outcomes, effective service coverage, financial risk protection, risk factor mitigation. And in terms of impact, improved health status, improved financial well-being, and improved welfare. How do we define UHC? The WHO said UHC means that all individuals and communities receive the health services they need, all, without suffering financial hardship. It includes the full spectrum of essential quality health services, from health promotion to prevention, treatment, rehabilitation, and palliative care. They say access to safe, effective, quality, and affordable essential medicines and vaccines to all. Now, it appears to be a bit of a utopian concept, saying that how can everybody in the population receive all the services they need without financial hardship? So came the first concept of pro-poor universal health coverage, focus on the poor. But then came the challenge. Programs that are designed only for the poor are poor in design and poor in delivery, because the rest of society doesn't have a stake in its success. So the idea is that it must involve every section of society. So it has to be truly universal. So they said progressive universalization, do it in parts progressively as more resources accumulate. So they then said, WHO came up with this cube. Let us have 3 dimensions. The population dimension, who is covered? Services, which services are covered? And financial protection, what do people have to pay out of pocket? What is the cost coverage? Now, population coverage is something that appeals to politicians, because they would like as many people to be seen as beneficiaries, potential vote bank. I'm not saying they're not interested in equity, but ultimately the political considerations will come in, even if the package of services is shallow. But the physicians, the doctors, the healthcare providers, they would like to see the best possible package of services. I want my patient to get a cardiac transplantation. I want her to get the best cancer chemotherapy. Why not? Because my patient deserves the best. So the physicians will focus on the service package, whereas those who are sitting in the finance ministries and the Niti Ayogs and health ministries will say, how do I use the available resources to provide the maximum financial protection to the most vulnerable groups? And how do I ensure that there is fiscal prudence so that the budget doesn't go bust? So these different perspectives will create a tension. And this tension has to be resolved by developing a package, which is a package of services, which can be the benefit package, which can be progressively expanded as more resources accrue. Primary care benefits all the three dimensions of the UHC cube because it covers the entire population across the entire life course. It has the largest package of services, and it is the most resource optimizing in use of financial and human resources. So UHC has to be led by primary health care. So we need to revitalize primary health services by investing more in rural and urban primary health services, strengthen sub-centers with technology-enabled non-physician healthcare providers, convert static facilities into nearer-to-home outreach facilities, improve physical and IT connectivity between sub-centers, PHCs, CHCs, and district hospitals, to improve referral and follow-up systems, promote integrated care through networks of providers, and enhance community participation and monitoring. So this would be the cumulative prescription for delivering UHC. Now, an essential health package is usually consisting mostly of primary care and several elements of secondary care, and limited, certainly life-saving elements of tertiary care. In rich countries, it is by exclusion. You decide, okay, I'm not going to give cosmetic surgery. But in low resource settings, it is a package of inclusion rather than of exclusion. The choices are based on individual and societal burden of disease, mortality, morbidity, disability, adjusted life year loss, the size of health impact on disease burden, cost effectiveness, degree of financial risk protection, affordability, which is fiscal space, and total cost and budget impact, equity, attention to vulnerable groups, feasibility, technical and legal restraints, and capacity for multisectoral action, health system readiness, is it adequately resourced, responsive, are there implementation constraints, scope, is it scalable, is it sustainable, acceptability, political alignment across different stakeholders, and public acceptance. All these matter while we are constituting the package. Now, in choosing a package, basically, cost-effectiveness analysis has been the principal way in which the package components are chosen. But Jamieson and Larry Summers also introduced the concept of what's called extended cost-effectiveness analysis, in which they say it's not just how much of health you're getting for the money that matters, how much of financial protection also are you getting for the money that's there. So are you actually preventing from people being pushed into poverty? A cardiovascular procedure may appear a little more costly and possibly not comparatively cost-effective when compared to something else. But if it is necessary, considered life-saving, and the family is going to spend on it anyway, and if they're going to be pushed into poverty because they're purchasing life at a high cost, then you have to really look at it as an important part of the package, because that's extended cost-effectiveness analysis, in which how much of financial protection also are you buying for the money that you're spending apart from the health. Equity matters, as I said, horizontal equity and vertical equity. Horizontal equity is where there is universal access to a common set of services and an essential health package, and a vertical equity where there are additional targeted services for disadvantaged or vulnerable groups, that services beyond essential health package. Since there is paucity of time, I'll skip over several slides. I'll only cover a couple of slides, but I'll leave the whole slide set with you for the future. So, one of the things that I'd like to mention is other countries have a very clear-cut system for identifying which components should go into the package. The National Institute for Health and Care Excellence in UK does an analysis of efficacy, effectiveness, and cost effectiveness, and says these should go into the NHS. Thailand has Health Intervention and Technology Assessment Program, HITAP, which is funded by the central government, federal health ministry, but is independent of the government, and they do the analysis and they decide which elements should be introduced into their composite health insurance system, where 3 health insurance programs have been merged together. We do not have a comparable system. ICMR was assigned that function, is doing it partly, but still not fully. Unless we actually set up a strong system for this, then there will be arbitrary choices exercised by both the central government-funded public health insurance programs as well as by the state government-funded health insurance programs. We need to push for this kind of evidence-informed decision-making. The measures for assessing success of universal health coverage are the degree of financial protection and the extent of service coverage. The questions that we ask of financial protection are: has it reduced out-of-pocket expenditure? Has it reduced catastrophic health expenditure? Has it reduced healthcare-related impoverishment? Now, here we bring in the concept of foregone care. Quite often we are seeing announcements by the government and elsewhere too that our out-of-pocket expenditure has decreased from 68% to 57% to 48% to now 43%. Excellent, it's very good. But the big question is there adequate service coverage? If the services are not available or affordable, people will not be spending even out of pocket. So we get a spuriously optimistic picture of out-of-pocket expenditure. So we must aim for good service coverage and reduce out-of-pocket expenditure as our goals, rather than just taking pleasure in showing only the out-of-pocket expenditure. And there, just to, we have done a bit of an analysis in our group, and different state-wise service coverage as well as financial protection. Now, there are some states who are doing very well in each. Here, this is not from the slide. What we need to do is, there are some states with a double deficit, that is poor service coverage as well as poor financial protection, like Bihar, UP and Jharkhand. We need to improve both service coverage as well as financial protection. What they need is greater investment in infrastructure, workforce development, free and entitlements for service delivery, rural-focused health workforce or human resources for health pipelines, and predictable primary care financing plus robust monitoring. So if we have to move UP and Bihar out of the current rut of poor health indicators, you have to improve both service coverage as well as financial protection. Then comes close the service finance gap in states like Kerala and Tamil Nadu, where the service is very good, excellent, but the financial protection is still not very good. Because if you look at Kerala, there's a tremendous dependence on the private sector. and for tertiary care, even in Tamil Nadu. So unless you actually close the service finance gap, even in these states, in this high coverage states where service coverage is high, you are still going to see disparities. Then that you have to do by tightening private sector regulation and expanding free services. Then leverage states with good financial protection as learning laboratories. Telangana with coherent insurance system, and Rajasthan with an excellent drug supply strategy. So try and pick up some of the exemplars and then try and disseminate the learnings across the various states. And institutionalize state UHC dashboards. Annually, we should be able to get, not once in a while, surveys. Annually, we should be able to get on the dashboards what is the current, in the previous year, what has been the service coverage like, what has been the financial protection like. Unless we start following them and monitoring them, we will not be able to see the performance of the health system, and certainly not UHC coverage. So these are some of the things that we need to do. I'll try and close up with a couple of more slides, no more. As I said, the slide set will be available for those who are interested. But the principal drivers of out-of-pocket spending and of catastrophic health expenditure are medicines, outpatient care with medicines, and diagnostics. People think that it's only hospital care that matters for catastrophic health spending, but 70% of all private health spending is out-of-pocket, is on outpatient. And about 60 to 70% of that is on drugs and diagnostics. That's the low-hanging fruit that we must tackle. If we can provide free drugs and diagnostics, then we would have eased a lot of financial hardship and certainly improved service delivery. And that we can do through pooled public procurement. Tamil Nadu does it, other states have not really followed, Rajasthan in part. But the Tata Memorial Hospital has shown, by uniting a large number of cancer hospitals across the country through the National Cancer Grid, that they negotiated for several cancer drugs, expensive cancer drugs, and lowered the price through collected bargaining using the power of monopsony, where there is a single purchaser, multiple providers, and the mean reduction in the cancer drugs that they procured was 86%, the median reduction. So that's the kind of example. So why can't our private hospitals form consortia, do a consortia purchase of drugs, equipment, vaccines, and pass on the benefit to the consumer, of the patient? So these are the kind of reforms that we need to push in this country, the states as well as the private sector too. I'm not going further into other slides. I'll close up with the last slide. Now, I look at health assurance as going beyond health insurance. And in fact, our Honorable Prime Minister did talk in 2014 of health assurance, saying it has to be not just health insurance. So drawing inspiration from that, let's look at what assurance means. Assurance can either mean make sure that all the services promised under UHC are delivered in a timely fashion with great efficiency and equity, with good assured quality, or it can go beyond that to cover health in all dimensions. Because health, as we all said, is determined by actions in many other sectors, even more so than in the health sector. So I view this in three concentric circles. Innermost is health financing, principally tax financed, because no country has achieved universal health coverage without a high level of government investment and public financing. This can be funding, health financing can be supported by social insurance and other insurance schemes. And in terms of delivering the entitlements promised by health financing, you need a strong health system. And that requires a multi-layered, multi-skilled health workforce, health management information systems, adequate infrastructure, governance, drugs, vaccines and technologies, community engagement, all of these matter. But we have to look beyond that if we want to create a healthy society. There are determinants of health that operate at the population level, like clean water, sanitation, food systems, physical environment, social stability. There are those that operate at the individual level, but again socially determined. The individual level, the level of education, occupation, income, gender, participation in social support networks. Unless we take all of these together, UHC will not be translated into health assurance. So we need to bring all the three circles together, and it is that calls for action which moves from silos to synergy. As the French social scientist Simone Weil said, attention is the rarest and purest form of generosity. Thank you very much for your attention.
Thank you very much, Professor Reddy, for that insightful and thought-provoking address. We can now have a short question and answer session.
Good morning, sir. Thank you for a really brilliant presentation with your wonderful insights. So one issue that has happened in India is that the skewed private financing, the skewed private expenditure and costing of health is driving two kind of behaviors. One is it is distorting the health-seeking behavior. A lot of people are seeking unqualified health providers. Then they are going in for, like you said, for medicines which are causing antimicrobial, issues. And the other thing is that this is also again pushing for greater public health financing, say for Ayushman Bharat and so on. But unfortunately, I don't know how we're going to address this, but so how do you think we should, do you think we can regulate the way the private sector health costing happens? Because in Ayushman Bharat, when the costing was done, one of the issues that came up was that private hospitals were constantly complaining about the lower prices which were being set for the healthcare packages. But the fact is that they are the ones who are actually distorted because they are charging far more. Do you think there's a way to regulate this?
Well, India's mixed health system has evolved by default and not by design. So ideally, we should have had a very strong and well-ensconced public sector supported by a private sector, but which is not driving the entire system. Unfortunately, that situation has not happened. Over a period of time, public sector has dwindled in resources and declined in performance. And the private sector has filled that vacuum. Now, what we need to do is to utilize a well-framed universal health coverage architecture to bring in the private sector more responsibly into the system. Imagine at a district level, suppose there is a public health emergency, COVID-like emergency or any other emergency. Does the district collector know how many private doctors are functioning in that district? How to bring them into the whole action area? So ideally, even in a steady state, we ought to be able to have a clear map of which are the public sector resources available, which are the private sector resources available, which are the voluntary sector resources available, and network them in a manner that they're all available for any service. And then fix the terms of service. The public sector has to be in the commanding role of design. The delivery can be split. Now, but accountability has to be there. Now it's a laissez-faire system. So that's not going to work. And the private sector does not want regulation. It does not want Clinical Establishments Act. But you have to bring them in. Fortunately, because many of them are beneficiaries now of government-funded health insurance schemes, we can impose this kind of regulations on them if we have the political will. But the individual private practitioners, the family-run nursing homes, these are going to be problematic. But even they can be brought in if they are going to be enlisted and ultimately said, okay, this is going to be the architecture at a district level, and you'll have to be available for services, and there has to be a network which will undertake the responsibility. And these are the accountability measures. I think this requires a certain amount of redesign, but fortunately, our Ayushman Bharat now permits that architecture through the health and wellness centers and others in the public sector. They're bringing in the private sector in secondary and tertiary care, but even in private care, primary care, in a responsible manner, we can bring them in. And those who don't want to be empaneled, fine. But as long as we build this network, then we can impose cost and quality restraints. And say that if you want government funding and you want government facilities for pool procurement of any drugs, then you have to be part of the system. You can't operate independent of the system. So I think we have some leverage which we must utilize. But accountability goes with it. Okay, the short answer to your question is the public sector has to be more responsive, the private sector has to be more responsible, and the voluntary sector has to be more resourceful. Jan Aushadhi is a very important scheme. It is, as long as it's quality assured. I mean, we don't have spurious cough setups coming in. Then, as long as it's quality assured, I think Jan Aushadhi is a very important element because generic drugs are going to be absolutely critical for ensuring the affordability of medicines. And the wider we can actually provide Jan Aushadhi, but we'll have to build public confidence. One of the things is there's a lack of public confidence in the quality of those medicines, and quite often the pharmacists themselves erode that confidence, saying they are branded nahi hai, wo chalega nahi, that kind of stuff. So we have to build up trust also in the system.
Highlighted both in the public and the private health, the structure and the availability, affordability, all the issues. Why and how should we best use the technology to leverage these issues, sir? Because right now we've had various models of startups and all in the country where digital healthcare has been, doctors availability at just 5 rupees. When we have a shortage of doctors in the primary healthcare centers, those have actually done a lot of filling in the gap. So could it be more structured, more as a, used as an enabler to address many of these issues, sir?
Actually, technology can be very helpful if appropriately used. Right from ensuring how our workforce deployment is taking place, who is reporting for duty, who is missing in action, to drug supplies. Are they available? Are there stockouts? What are the service needs where at a block level the supplies are getting depleted, to forecast what the need for replenishment is? So many areas, but equally importantly for referral chains, right from primary to secondary and secondary to tertiary on the way back as well. I think technology is going to be extremely helpful. And the ABHA card, the health accounts, Ayushman Bharat health accounts, if we can actually increase the number of people who actually have an ABHA card and unify the medical records, portability of medical records is going to be very important. Not only the patients exercising a right, or the family exercising a right, when you move from provider to provider, whether even at the same level, you move from a cardiologist to a diabetologist, or whether you move from primary care to secondary care and back, then I think having this kind of consolidated records is going to be very important. The other element which has not been much talked about is you can also bring in social determinants into public health planning. See, you have to look at which are the most vulnerable sections in terms of either geography or gender or in terms of socioeconomic resources, caste groups, and you may have to plan your allocation of resources, concentration of your program efforts based on vulnerability as well. And actually now big data can be analyzed and compiled through AI, and lot can be done through technology.
Sir, I had a question. Dr. Reddy, it's a pleasure and a privilege to hear you speak every time. I'd worked in the National Rural Health Mission around a decade ago, and the issues that came up, human resources for health, absorptive capacity of health financing resources, and the fact that health is a state subject. So that trifecta of issues which impact healthcare service delivery still remains. Be grateful for your views on this and any way forward that you can speak of.
Well, let me deal with each of them if possible. As far as human resources for health is concerned and absorption capacity is concerned, they're also interlinked. If you, the classical argument that's been made by planners is you're not able to absorb the money allocated. If you look at the budgetary estimate and the revised estimate, in many programs there is money underspent. You're not able to absorb, then why are you asking for more money to be allocated? It's like trying to squeeze a watermelon through a garden hose pipe if you put in more money into a system that's not functioning. But the problem there is you have inadequate health workforce, you have inadequate supplies, and inadequate infrastructure. Unless you do some front-end spending in order to improve those, the absorption and utilization capacity of the health system will not improve. It's like telling that, oh, the child is sick, not able to eat, therefore let's starve the child. In a sense, unless you actually do some front-end spending to improve the capacity of the health system, the utilization and absorption will not increase, and we have to do that. As far as the health workforce is concerned, there will be constraints. There are constraints. But I think that's because we have followed mostly a doctor-centric model. And while doctors are needed, certainly at the CHC level, some specialists will be needed. Much of our primary care can be delivered by technology-enabled non-physician healthcare providers, both in rural and urban areas. And this has been shown very well in many parts of the world, including in India, that even diabetes, hypertension, all of this can be managed very well. Maybe an initial detection may require a physician, even that's not always necessary. Point-of-care diagnostics, handheld devices with decision support systems. Unless we actually reduce the doctor-dependent model and keep the doctors for where they're really needed, we are going to see this kind of workforce shortages happening. And secondly, we ought to be able to use community resources as well. Community-based organizations should be utilized to enhance health literacy, nutrition literacy, promote self-care, family-assisted care. Wherever there are gaps, we ought to be able to try and fill that in. But I think human resource production is a very important element, and we ought to focus on that. Doctors are also needed, particularly specialists are going to be needed. That's why we ought to upgrade our district hospitals, increase their infrastructure, increase their resources, utilize the specialists who are already sitting there. They have a huge patient population, they have accumulated experience. Why are we not utilizing them as teachers? Why are we not utilizing them to train in future other specialists? So converting them into medical colleges and nursing colleges is going to be an important element. So we ought to utilize many of the things that we have not done in the past, and we can actually meet some of our human resources for health shortages also, partly by departing from the doctor-dependent model and partly by upgrading our district hospitals. The third, of course, was service coverage, you said, ma'am? What is the third element you said? You mentioned three, the trifecta. What is it?
State subject and the constraints that come along with that.
Center-state relations.
Yes.
Okay. I know, it's a state subject, certainly, but it depends entirely on the politics of the country. If we really, I'm not getting into the political horizons of whether the central and the state government are having harmonious relationships or not. As long as we recognize that policy is ideally set at the national level, planning is done at the state capital level, and implementation is done at the district level, then I think we are in a reasonably good shape. There has to be a lot more of autonomy at the level of the district in terms of actual implementation. And we must also recognize that if one state doesn't do well, it pulls down the national aggregate as well. So it's important that all states and center work well together, but it is at the district level that really we need a lot more of decentralized functioning. So I would say what we need is digitally enabled, decentralized, district level implementation of programs and people partnered public health.